Hello everyone, my name is Lauren Heinecke and I'm an assistant professor of pharmacotherapy at the University of Maryland School of Pharmacy. And today it's my pleasure to be with you talking about part 6 of our Antibiotics from Head to Toe series. Today our focus for the antibiotic series is going to be on diarrhea. We have some objectives for our talk today, so by the end of our time together you should be able to identify the most common pathogens seen in diarrheal illnesses in the United States. After we talk about the epidemiology and etiology of diarrhea, we're going to go into talking about comparing and contrasting the clinical signs and symptoms that are associated with diarrheal illness and how that can help you identify what your most likely pathogen is that's causing the illness. From there, we'll talk about the role of diagnostic testing in diarrheal illness and how to make the most of your diagnostic testing. After we talk about diagnosis, we'll move into treatment, and we're specifically going to focus on describing the role for antimotility agents in the treatment of diarrheal illness. And we're also going to spend a decent amount of time talking about how to develop a treatment plan for a patient who has Clostridium difficile or nosocomial diarrhea. Before we talk about our epidemiology, I wanted to give us a few definitions to make sure that we're all on the same page. And many of you, I'm sure, have definitions you use for diarrhea, but I think it's nice just to see what the formal one looks like. So, diarrhea, as defined by the Infectious Disease Society, is alteration in a normal bowel movement characterized by an increase in the water content, volume, or frequency of stools. And it's also defined further as a decrease in consistency and an increase in frequency of bowel movements to more than 3 stools a day. So you can see that some of the most important characteristics are exactly what that stool looks like, and then so really the consistency and then also the frequency. And so those are going to be consistent things that we talk about throughout the presentation today that will help lead us down the road of what is our most likely pathogen, those specific characteristics. The next definition is infectious diarrhea, and this might seem relatively obvious, but it's diarrhea due to an infectious etiology. Certainly we have diarrhea that can be due to other causes, that can be due to other disease states, or it can be due to medications. Infectious diarrhea often is accompanied by symptoms of nausea, vomiting, or abdominal cramps. So oftentimes there are other signs and symptoms that go along with infectious diarrhea, which may be absent from some of our other causes of diarrhea. We also have to talk about the time frame for diarrhea. So acute diarrhea is an episode of diarrhea that lasts or has been going on less than 14 days in duration. Once we hit a diarrheal episode that's been going on longer than or equal to 14 days, then we're starting to talk about persistent diarrhea. And there are different pathogens which we're going to talk about if we think we've got an acute episode of diarrhea or if we have a persistent episode of diarrhea. So the definitions hopefully will keep us all on the same page and on the same track going through the rest of the presentation. So now we'll move into the epidemiology. Why do we care about diarrhea? Should we care about diarrhea? And so this is some old data, but really the data hasn't changed in terms of the number of diarrheal episodes we have in the United States. It's estimated that every year we have between 211 and 375 million episodes of diarrheal illness here in the United States. Ultimately, what does that result in? Well, it results in about 73 million physician consultations, more than 900,000 hospitalizations, and more than 6,000 deaths. Now, I think it's important to identify who is most commonly at risk for hospitalization and death in the United States. And here in the United States, most of our hospitalizations and death occur in the elderly, so defined as those over the age of 60. So I think that's an important piece to keep in mind. These are the folks that are going to have more issues with dehydration and really going to need additional care, really have a higher severity of illness associated with these diarrheal illnesses. Now, this is a little bit different than what we see in the rest of the world. So in the rest of the world, dehydration associated with GI infections is a huge cause of morbidity and mortality. But now, instead of talking about our elderly patients, we're talking about infants and children under the age of 5 that are at the greatest risk. So just important to think about if you're, doing any sort of medical mission trips to some of the underdeveloped countries where diarrheal illnesses are more common, and really it's those infants and children that we're really concerned about. We'll talk about which countries have some of the highest risks as we go through the presentation. Now, the most common cause of infectious diarrhea in hospitalized patients in North America and Europe is Clostridium difficile diarrhea. So we're going to spend a lot of time talking about the treatment for Clostridium difficile diarrhea, talking about how we determine the severity of illness and really how that leads us down a specific treatment path for patients. Now, when we talk about the etiology of infectious diarrhea, we really have two specific main areas of pathogens that we're looking about. So we have bacterial pathogens and we have viral pathogens. And so our bacterial pathogens include things like Vibrio, E. coli, Salmonella, Shigella, Campylobacter, and of course Clostridium difficile is on there as well as a bacterial cause of diarrhea. In terms of common viruses that cause diarrhea in the United States, we're talking about things like rotavirus as well as norovirus, astrovirus, and enteric adenovirus. So lots of different things that can cause diarrhea. And we've talked about the most common cause of nosocomial diarrhea is going to be Clostridium difficile, which is why we're going to spend a fairly lengthy amount of time talking about how to appropriately treat patients with C. diff. So when I was thinking about how I was going to break this talk up for you and how it was most manageable in terms of talking about the different causes of diarrhea, I thought the two best ways to break it out are to talk about some information on travelers' diarrhea, since many of the pathogens we included in our etiology are frequently associated with travel to foreign countries. Then I also thought we'd break it into Clostridium difficile diarrhea, just so you have a general sense as to how we're sort of going to break things up and talk about them for the rest of the talk. So starting with just some general information on traveler's diarrhea. Many of these items we've already covered, and in fact with our infectious agents we also can have protozoal causes of diarrhea, including Giardia. Viruses are also a player, and then our major bacteria are E. coli, Campylobacter, and Shigella species. So those are the most common pathogens that are seen in traveler's diarrhea. The transmission for traveler's diarrhea is ingestion of preformed toxins in contaminated food or water. So it's important when you're traveling to some of the countries we're going to talk about in a little bit to be very careful about food and water supply and what kinds of things you're taking in. It would certainly put you at increased risk if you're just, drinking water potentially out of the tap at the hotel, or just eating, fresh fruits and vegetables. Many of the recommendations are in terms of decreasing your risk of getting traveler's diarrhea in some of these countries are to stay away from anything that doesn't have a peel. So apples would be a bad idea. You'd want to stay away from things that you wouldn't be peeling. Bananas, probably okay. Oranges, probably okay. And so in terms of epidemiology, how many travelers do come down with traveler's diarrhea? It's anywhere between 30 and 70% of travelers. And I think a lot of that just has to do with the precautions that they take and how educated they are before traveling. So I wanted to also just go over a little bit of the pathophysiology of Clostridium difficile diarrhea before we move into talking about the differences between the types of diarrhea and how to think about which pathogen is most likely. So with Clostridium difficile diarrhea, it is a gram-positive spore-forming anaerobic bacillus, so it is a bacteria. And so essentially what happens in general with Clostridium difficile is that most people are on antibiotics who develop Clostridium difficile, and the antibiotics disrupt the normal colonic flora, and ultimately that leads to colonization with Clostridium difficile. The Clostridium difficile bacteria produce toxin, and so it produces toxins A and B. Those are released by the bacteria. And this is ultimately, the toxins are the pathogenic part of this disease. The toxins are what cause the diarrhea as well as the colitis. And then there's a wide range of disease severity. It can range from mild diarrhea to life-threatening toxic megacolon and pseudomembranous enterocolitis. So it's very important to take this disease very seriously and to treat patients appropriately and in a timely fashion. Okay, so we've gone over a lot of basic information about the different causes of diarrhea and the most common cause of diarrhea here in the United States, and we have a good sense as to what our numbers look like in terms of the number of people who are treated for infectious diarrhea on an annual basis. I thought the next thing that would be important to talk about is the characteristics of the stools, and then how we determine what are the most common etiologies or the most common pathogens that are likely causing the diarrhea. So just before we go into talking about the table, remember diarrhea is defined as a decrease in the consistency of bowel movements and an increase in stools to more than 3 per day. So just to orient you to the table here, we have diarrhea broken down into two different types. So essentially when we talk about it, you can have either watery diarrhea or dysenteric diarrhea. And many of our differences are based on these two classifications. So then on our left-hand side, the things that we're going to compare are the stools, so specific characteristics of the stools. From there, we have the mechanism, so what is the mechanism behind the disease causing the illness? We'll talk about complications in the subsequent row, and then the last row goes into the etiology, helping you to think about how you need to be treating these patients, what kinds of tests you want to be doing. So when we talk about watery diarrhea, appearance is generally watery, which sort of makes sense. The volume is significantly increased, so more volume generally than in dysenteric diarrhea. The number per day is usually less than 10 for watery diarrhea. If you did a test for occult blood, which generally is a good test for colon cancer screening, but if you talk to any of the physicians that I work with in general internal medicine, they'll say it's a worthless test for anything else. But if you did an occult stool test, it would generally be negative in watery diarrhea. And if you took a look at the stool, generally there would be few or absent polymorphonuclear leukocytes. Now, in comparison to dysenteric diarrhea, the appearance of dysenteric diarrhea is frequently bloody. It has increased volume, but not as great a volume as watery diarrhea. Generally, in dysenteric diarrhea, we're talking about more than 10 bowel movements a day. If you did the occult blood test, often it would be positive, and there would be many PMNs if you took a look at the stool. So then taking a look at the difference in mechanism in watery diarrhea, it's toxin-based as well as reduced absorption. In dysenteric diarrhea, we specifically have mucosal invasion. In addition, we'll take a look at complications. In watery diarrhea, complications frequently include acidosis, shock, and electrolyte imbalances. Probably the reason for those specific complications seen with watery diarrhea are you have such an increased amount of volume. It's such a large amount of volume that people really have difficulty with those specific types of complications that really speak to dehydration and fluid loss. Certainly you can have those same complications in dysenteric diarrhea, but the more common complications are going to include tenesmus, rectal prolapse, and seizures. But certainly you could have the same complications as watery diarrhea as well. So then let's look at our etiology. In terms of watery diarrhea, we're talking about some of our viruses, so rotaviruses and norovirus. We're also going to include two different types of E. coli as well as Vibrio. Then the majority of the rest of our pathogens are going to be in the dysenteric column, so Shigella, Campylobacter, Salmonella. E. coli can also be included in dysenteric. And then Clostridium difficile diarrhea is going to be in dysenteric. So E. coli is a little bit complicated in that it can fit into both categories. So hopefully this table and this comparison helps you to think about what pathogens are most likely based on the appearance and the volume and the number of stools. So really taking a good history is an important part of the diarrhea workup. And on our next slide, we're going to talk about an algorithm for diagnosis. So what specifically should you be taking into account when you're trying to figure out what specific pathogen is causing someone's diarrhea? So taking a look at this slide, so the most important pieces for determining the pathogen that's causing someone's diarrhea is first to evaluate the severity and the duration. So the duration specifically, remember we talked about acute and persistent, so 14 days is our cutoff. If it's less than 14 days, we're still talking about acute diarrhea. If it's lasted more than 14 days, we are starting to think about persistent diarrhea, and you'll notice that on this table it specifically says more than 7 days. So we'll kind of use 14 days as our general definition, but oftentimes we start to think about other potential causes if it lasts even longer than 7 days, but the standard definition is more than 14 days. So after we've evaluated the severity and the duration, we're going to obtain a history and a physical examination. The history is really important in terms of looking for risk factors. So what types of risk factors does someone have for specific pathogens? And we'll get into talking about that patient evaluation and patient factors that put them at increased risk for specific pathogens on the next slide. After that, we really want to go ahead and treat their dehydration. So knowing that many complications can result because of dehydration. So making sure fluids are a part of our treatment algorithm is important. And then if there seems like there's an outbreak, certainly that would be important from an epidemiology standpoint, and making sure that if there's something specific going on. So I'm sure many of you have heard about the different outbreaks that have occurred different places in the country. I believe most of them were with E. coli, oftentimes with different fresh fruits and vegetables. And so if there's an outbreak that seems like there's going on, they can try to find the cause of that outbreak and then prevent other people from getting sick. So reporting outbreaks is particularly important to help prevent additional folks from getting sick. And so after you've done all of that, now you're going to think, okay, what am I most concerned about? And that's going to help you in terms of determining what tests to order and how to think about treating your patient. So after I've gone through the severity, duration, history, physical, am I concerned about community-acquired or traveler's diarrhea? And this is especially important to consider if you have a patient who has a fever or they have blood in their stool. And our pathogens that we're going to be concerned about include Salmonella, Shigella, Campylobacter, E. coli, and Clostridium difficile diarrhea. So I wouldn't recommend ordering tests for all of those. We'll talk specifically about which tests are probably most important in a few slides. The next question is, am I concerned for nosocomial diarrhea? And nosocomial diarrhea, we typically start to think about diarrhea that starts greater than 3 days after the person has been in the hospital. So how long have they been in the hospital? What is their risks? Have they been on antibiotics? And at that point, if I was concerned about nosocomial diarrhea, you'd go ahead and test for C. diff, and we'll talk about the test for C. diff in a few slides. And then the last box in our algorithm is persistent diarrhea. Persistent diarrhea you especially want to think about in a patient who is immunocompromised. And so we're going to start thinking about parasites in persistent diarrhea, thinking about Giardia, Cryptosporidium, Cyclospora, and Isospora belli. And then if the patient is HIV positive, we're also going to consider Microsporidia and MAC, or Mycobacterium avium complex. Certainly, GI invasion of MAC can cause significant persistent diarrhea. So we're sort of going to go down this path of trying to determine which are our most likely pathogens. And our next slide, in terms of talking about patient evaluation, I think is really going to help us do that. So when we talk about patient evaluation, we're going to talk about clinical features, and we're also going to talk about epidemiologic risk factors. So we've already sort of talked about many of our clinical features in a couple of slides prior to this one, but the first one is how and when did the illness begin? That's an important characteristic. The stool characteristics, which we've talked about on the previous slide, and then we've talked about frequency and quantity of stool produced, are important in terms of determining if it's most likely watery or dysenteric diarrhea. Does the person have any sort of dysenteric symptoms? And then next we're going to talk about volume depletion symptoms and any associated symptoms. So really getting a good history and physical exam from the patient are a key part of our patient evaluation. In terms of also obtaining some history from the patient, we also want to look for epidemiologic risk factors. So have they been traveling? And then we'd get into talking about what types of foods did they eat while they were traveling, what was the country, how long did they spend in each of those countries. So traveling can certainly be an important part of determining what our most likely pathogen is. Daycare exposure. Certainly many of our viral illnesses are very predominant in young kids, and then, from there asking about sick contacts. Was anyone else sick? If you come in contact with anyone with a recent diarrheal illness, certainly Clostridium difficile diarrhea is very easy to contract from somebody else. And we'll talk a little bit about preventive measures to prevent contracting C. diff from someone who has it. Consumption of unsafe food, so I mentioned that when I talked about travel. Certainly that could also be something that occurs in the United States, particularly when we're having an outbreak. So really reporting those outbreaks, as I've mentioned earlier, is an important piece of the algorithm. The next thing is swimming or drinking from unsafe water sources. So really getting a good history about food and water sources that people have been eating and drinking from is an important piece of the evaluation. Contact with animals and reptiles. Some of these diseases can be contracted from being in contact with animals and reptiles, so that's an important piece, although maybe less frequent in terms of epidemiologic cause, still an important question to ask. Recent antibiotics, and this gets to thinking about Clostridium difficile diarrhea. And then underlying medical conditions really helps us in terms of thinking, are they immunocompromised? Are we going down the persistent diarrhea cause? And if they're immunocompromised, it leads us to think about things a little bit differently than if they're immunocompetent. Okay, so we've talked a lot about algorithm for diagnosis and patient evaluation, and we've talked a lot about specific travel. Well, what specific locations are at highest risk for travelers' diarrhea? That's the information that's contained in this slide. So you can pretty much forget the low-risk countries. Those are not countries you're going to travel to and really have concerns about travelers' diarrhea. The ones that you're going to be more concerned about are those with intermediate risk and high risk. So intermediate risk countries include Eastern Europe, South Africa, and some of the Caribbean islands. High-risk countries include most of Asia, the Middle East, Africa, Mexico, Central America, and South America. These are the countries where you need to be more careful with what you eat and drink. Take greater precautions. If you're traveling to those countries, you probably want to get a prescription and take along some medication used to treat travelers' diarrhea. So fluoroquinolone or azithromycin are nice options to take along. And so there's additional information about this in the Yellow Book, which is available for free if you go to the CDC's website if you have more questions or concerns about travelers' diarrhea. But it's the high-risk countries that we're going to be most concerned about. And when we got our history, if someone had recently traveled to those high-risk countries, it's going to put those travelers' diarrhea pathogens higher on our differential in terms of what's causing the diarrhea. So I actually don't have a specific slide about diagnosis because a lot of it we've just gone over. Much of it is related to history, and it's related to exactly what that stool looks like, what the volume is, what the number are. So we are able to do stool cultures, and these are things that are commonly requested, but they oftentimes don't provide much additional information. So when we're thinking about doing a stool culture, we want to refer back to our algorithm for diagnosis, and we really only want to get a culture for the things that we're concerned about. And so we go back to our algorithm for diagnosis, we go back to our slide that takes a look at specifically comparing watery versus dysenteric diarrhea, and then we also take into consideration what information we gained from our patient in terms of determining which stool culture. So a lot of it is based on the history in terms of determining which stool culture is going to be most appropriate. The other, I think, really nice thing that was in the guidelines that came out from the Infectious Disease Society of America, and I realize they are old guidelines, but not a whole lot has changed in terms of management of infectious diarrhea, is that in terms of getting a stool culture, to get the most bang for your buck, consider the following, using the 3-day rule. The 3-day rule really only pertains to someone who's developed diarrhea in the hospital. So if somebody's been in the hospital longer than or equal to 3 days, you probably don't need a stool culture because the yield in terms of ova and parasites, or specifically E. coli or Salmonella or Shigella is very, very low. The likelihood that it's those pathogens is very, very low. It's probably Clostridium difficile. So if they've been in the hospital 3 days or longer, in general, I will say that we do not need a stool culture. And back when the guidelines were published in 2001, they presented some data from the mid-90s that basically showed we were getting stool cultures in as many as 50% of patients that presented with diarrhea, and that if they decreased the number by using this 3-day rule, it would save, I believe it was in the millions in terms of the amount of dollars that could be saved. And then the last piece of this that I think it is important to consider is the sensitivity and the specificity of the test that you're using. So we'll talk on the next slide about the definition of sensitivity and specificity, because I think we can all use a refresher on the definitions from time to time. But considering the sensitivity and specificity can help you in determining the utility of your test. So sensitivity is a test result that is positive in a patient who has the disease. So it's how likely are you going to get a positive in a patient who has the disease. And then specificity is a test result that is negative in a healthy patient or a patient who does not have the disease. So hopefully that helps. So sensitivity is positive in a patient who does have the disease. Specificity is negative. It has a high specificity if it's going to be negative in a patient who does not have the disease. So sensitivity and specificity, I think, are especially important when we talk about testing for Clostridium difficile, which is what we're going to talk about on this next slide. So specifically when we test for Clostridium difficile, it's a toxin test. And so there are more tests than this, but I would say these are the two most common, and I was trying to keep it a little bit simplistic for our purposes today. So most hospitals use the EIA, or the Clostridium difficile toxin A and B rapid immunoassay test, for a long time. And when I was a pharmacy student and a resident, and when I first started my practice in the hospital, this is what the test that we had. Since then, I think it was just in the last year or two, we actually switched over to a Clostridium difficile DNA toxin test. What I want to highlight is the difference in sensitivity. So the EIA, or the rapid immunoassay test, only had a sensitivity of between 63 and 94%, whereas the specificity was higher, about 75 to 100%. And so frequently it was used in practice that we would get 3 EIAs to make sure that we weren't going to miss somebody who was positive. And that's because of the low sensitivity, or the low likelihood that we'd have a positive test in a patient who had the disease. So we would be concerned about getting a false negative result, and as a result would do 3 tests. Now that we have this PCR test, or the DNA toxin assay test, the sensitivity is 95%. So we have only a 5% chance of having someone who has the disease and tests negative. Specificity is also better, it's 95%. And so now, as a result, we are not sending 3 tests, we only send 1 test. So I bring this up because I think it's very important for you to know which test was used to diagnose the C. diff, or actually not to diagnose it, because if it's been diagnosed, that's a good thing, but to know which test is being used to diagnose. Because if you have a negative result and you're still using the EIA, it might be pertinent to get additional tests, because there's a higher likelihood of someone having the disease and the test being negative. So sensitivity and specificity are important in terms of thinking about your Clostridium difficile toxin assay tests. We're not going to get into the specific sensitivity and specificity with our other stool culture options, but I think as a general principle, even in terms of thinking of other tests not related to infectious diseases, sensitivity and specificity are incredibly important when thinking about how powerful, or really how powerful your test is. So I just bring it up because I think it's a good review, and important concept for us all to be aware of. So now that we have all of that great introductory material under our belt, the rest of the time we're going to spend talking about treatment of patients with infectious diarrheal illnesses. So the first key part of our treatment discussion is that the patient needs rehydration. So the most common risk with diarrheal illness is dehydration, and in developing countries there's a significant risk of malnutrition in children. So rehydration is a critical part of the initial treatment of patients who have infectious diarrhea. And in general, we are going to use a glucose or starch-containing electrolyte solution if the patient can tolerate oral fluid. So you see lots of different options up there. I have Pedialyte up there. There's specific oral rehydration solutions, which are very common in developing countries, very common if you've attended any medical mission trips, frequently using Gatorades or chicken broth, anything that the patient can keep down that has glucose or starch-containing items in the specific solution itself. Certainly, we might have to consider using IV fluids, particularly in our hospitalized patients. And I know for my son, when he had an illness where I was concerned about dehydration, we actually used the Pedialyte pop. So sometimes ice pops can be a nice, fun option, especially if you have a child who's sick and you're concerned about dehydration. The next part of our treatment discussion is the role of antimotility agents in infectious diarrheal illnesses. So we have 2 options. We have diphenoxylate and we have loperamide. I think the key piece of information that I want everyone to walk away from this is that these antimotility agents are contraindicated in patients with toxin-mediated diarrheal illnesses, so specifically Vibrio and Clostridium difficile diarrhea. I think it's especially important to highlight that it's contraindicated in a patient who has C. diff. And the reason for that is that the antimotility agent actually decreases the clearance of the toxin as well as slowing down the stool production. So while it may make the patient more comfortable immediately, the retaining the toxin in the GI tract actually increases the disease burden and can be significantly affect the disease process. So you do not want to use antimotility agents if you're concerned about Vibrio or if you're concerned about C. diff. Now, if you've ruled those things out and you don't think that it's anything that's toxin mediated, certainly at that point you can consider giving an antimotility agent. I think the other important piece of this is that, it is a specific recommendation in terms of the amount. So with loperamide, you don't want to use more than 16 milligrams in a day. So I have the dosing listed up there for your reference. So those two slides are really our general diarrhea treatment recommendations. Then now we're going to move into some more specific treatment options. So we'll start with specifically traveler's diarrhea, since we're really breaking it into traveler's diarrhea and those pathogens, and then we're going to talk about Clostridium difficile treatment options in more detail in just a few slides. So the first piece we've already talked about, the oral rehydration therapy, is key. Our antibiotics that we can use are a few fold. So fluoroquinolones are a really nice option. Ciprofloxacin or levofloxacin at the dosing you see up there, it's only for 3 days. We can also use Bactrim for 3 days. And azithromycin is going to be our first line option in our pediatric patients. All of them are for 3 days. So if you're traveling to any of those countries that have a high risk of traveler's diarrhea, I think it would be pertinent to take a supply of one of these agents along just in case anything happens. Hopefully nothing will. Hopefully you'll take appropriate precautions, but always good to be fully prepared. And then you can also do antimotility agents as well. Loperamide 4 milligrams once. After that, 2 milligrams with each loose stool for a max of 16 milligrams per day. So those are your general traveler's diarrhea treatment recommendations. The next two slides are treatment that are directed at specific pathogens. So if you get a stool culture, you know that it's one of these specific pathogens. At that point in time, you could switch specifically to one of these more pathogen-directed agents. So if you've got enterotoxigenic, so basically the way things are broken down is enterotoxigenic, so those we're talking about generally toxin-mediated diseases, and then we have invasive diarrhea on our second slide. So our enterotoxigenic pathogens include Vibrio, a specific type of E. coli, and Clostridium difficile. So you can see that the treatment options are based on first-line agents and then alternative agents. So what you can see is that doxycycline, Bactrim, and Cipro are listed up there for Vibrio and E. coli, which are going to be frequently traveler's diarrhea-associated pathogens. You see some alternative agents up there, but in general, Cipro and Bactrim are really, really great options to cover almost all of your traveler's diarrhea-associated pathogens. C. diff, we're talking about different treatment options, metronidazole, vancomycin. An alternative is Fidaxomicin. We'll go specifically into talking about how you're going to choose one of those agents in just a few slides. Our invasive diarrhea pathogens include Shigella, Salmonella, and Campylobacter. So our first-line agents for those pathogens are in our middle column. Our alternative agents are in the far right-hand column. And again, you're going to notice you see Bactrim and Cipro listed with alternatives of azithromycin, some cephalosporins, and erythromycin is listed for Campylobacter. I think that would be relatively cruel for someone who's already having diarrhea. I'd probably stick with an azithromycin for that patient. So, but you'll notice that all of our pathogens that are commonly associated with traveler's diarrhea, you can use Bactrim, Cipro, or azithro. So if you have someone who comes in and you're concerned about traveler's diarrhea, you could really pick any of those three as initial treatment until you're waiting for your stool studies to come back. And if someone's getting better and you've tried one of those three agents, I think that the other question is how important are those stool studies if you've gotten a really good history and you're fairly certain that it's a traveler's diarrhea. So those are your specific pathogen-directed therapies in terms of what's recommended from the Infectious Disease Society of America. And again, you'd use those recommendations if you got a stool culture and had a specific pathogen that you knew you were treating. But again, our general traveler's diarrhea treatment recommendations really are going to cover all of those potential pathogens. So we're moving on to the last of our topics. We're just about done. How are we going to treat Clostridium difficile diarrhea? How are we going to determine which treatment option we should be using? And our treatment options, as you remember from our last slide, are really metronidazole or vancomycin. So the key is to think about our clinical definition. And so on this slide, the most recent guidelines were published in 2010. So our clinical definition and the different clinical definitions are in the left-hand column. The center column gives you your clinical data, which you're going to use to determine what your clinical definition is. And then the recommended treatment is in the far right-hand column. So it's important to keep in mind this data when you're recommending a specific antibiotic therapy. So if you have a patient who it's their initial episode and it's uncomplicated and mild to moderate in severity, that's defined specifically by looking at your white blood cell count as well as your serum creatinine. So if you have a white blood cell count or leukocytosis that's less than 15,000, and you have a serum creatinine that's less than 1.5 times the premorbid level, so you have a patient who is not significantly dehydrated or does not have any acute kidney injury associated with their dehydration, your initial treatment recommendation is going to be metronidazole, 500 milligrams, 3 times a day, and you're going to be treating for 10 to 14 days. A lot of the duration is dependent on how your patient responds. If they respond fairly quickly in terms of how quickly their diarrhea resolves or seems to be getting better, you can probably go with 10 days. If it seems to take a bit longer to resolve, you probably want to stretch it out to 14 days. Our next clinical definition is the initial episode, but now it's severe. And severe is defined as a white blood cell count or a leukocytosis that's greater than 15,000, or a serum creatinine that's greater than or equal to 1.5 times the premorbid level. So you don't need to have both of these, just one or the other. And so again, we've got a significant acute kidney injury occurring with the disease and the dehydration. So for these patients, you're going to want to recommend vancomycin. And you've seen lots of different dosing, I'm sure, 125, 250, 500. For all intensive purposes, the 125 milligrams PO 4 times a day is just fine. And again, your duration is generally 10 to 14 days, really dependent on how the patient responds. So you're going to want to use vancomycin in your more severely ill patients. The next clinical definition is it's an initial episode, but now it's complicated. And complicated means that the patient has hypotension or shock, megacolon, perforation, or severe colitis that can be seen on a CT scan. The next item that you're going to want to consider in your treatment recommendation is whether or not the patient has an ileus. If they don't have a complete ileus, you can recommend vancomycin 500 orally or via NG tube 4 times a day. In addition to metronidazole, you're going to give your metronidazole intravenously, so 500 to 750 milligrams IV every 8 hours. So you're going to do both therapy because these are very sick patients. I think the other important item that I didn't point out when we talked about vancomycin is it's always oral. We're not using IV vancomycin for people with Clostridium difficile diarrhea. And the reason is that you're treating the infection locally. So the oral vancomycin is not absorbed, and so you're able to treat that infection locally. You don't want to use intravenous vancomycin. We're recommending IV metronidazole in this case because we can still get relatively high concentrations in the GI tract, whereas we know with IV vancomycin we have a more difficult time achieving high enough concentrations to treat infections in specific locations. Now, if we have an initial episode that's complicated and the patient has a complete ileus, now we're going to use IV metronidazole, same dosing listed above, with rectal instillation vancomycin. So knowing whether or not the patient has an ileus is important. So those are our treatment options for initial episodes, and it's based on the clinical data which determines how serious, how severe the infection is. The last 2 rows of our table here are talking about recurrence. So the first recurrence, and recurrence is defined as occurring within 8 weeks of the initial infection. The recommended treatment is the same as for initial. If you have a second recurrence which is defined as within 8 weeks of the previous infection or the first recurrence, now you're going to switch to vancomycin if you used metronidazole before. And you consider doing a tapered or a pulsed course of therapy with the different dosing. So that's when using the different dosing is going to come into play. So The other key piece of this is that if somebody is on antibiotic therapy for another infection and it's possible to get rid of that antibiotic, certainly that would be an important item to do, because certainly that's what's contributing to the patient developing Clostridium difficile diarrhea. As we've mentioned before, we do not want to use antimotility agents in these patients as well. And then the last piece that I want to bring up for discussion is in somebody who has end-stage renal disease. So somebody with end-stage renal disease, you can't look at their previous serum creatinine, right? Because they're being dialyzed. So how do you know they're not going to have AKI on top of their end-stage renal disease, right? So you really can't use that serum creatinine as a marker. And there's not specific studies or recommendations that I've found in terms of what to do, but what I have found is that patients with end-stage renal disease seem to have more complicated disease. They seem to be a sicker group of patients. So when I've had end-stage renal disease patients come in and have Clostridium difficile, my recommendation is to use vancomycin, because they seem to have just a more difficult treatment course. They seem to have more morbidity and mortality associated with the development of Clostridium difficile diarrhea. So that's what I've taken away from the literature in terms of how the patients with end-stage renal disease respond to infection with Clostridium difficile. But again, there's no specific data to say you specifically need to go with vancomycin. And I haven't found any recommendations out there from any societies that recommend that as well. So certainly you could go with metronidazole and not be wrong. I just wanted to share with everybody my thought process in terms of how I've thought about that particular question. And the last piece of information that I wanted to talk with everyone about before we wrap up here is that since the guidelines were published in 2010, we've had a new agent that was approved for the treatment of Clostridium difficile diarrhea. So in 2012, Fidaxomicin or Difficid was approved. Its therapeutic class is a macrolide antibiotic with bactericidal activity, and it's only indicated in adult patients with C. diff diarrhea. In terms of pharmacokinetically, it is minimally absorbed and excreted in the feces, and the most common adverse reactions associated with it are GI in nature. The dosing is 200 milligrams twice a day for 10 days. I think the important piece to consider is the cost. It's $2,600 per course, which is relatively expensive. So with that general information in mind, let's talk about the place in therapy for Fidaxomicin. So there have been 2 clinical trials that have compared Fidaxomicin to vancomycin, and both have proven it non-inferior for clinical cure, but it was superior for the development of recurrence and global cure. So in terms of recurrence rates, it was 12.8% for Fidaxomicin and 25.3% with vancomycin, with a significant p-value of 0.002. Of note, patients with more than recurrence were excluded, and 80% of the patients included had a first episode. So we're only talking about 20% of the population included in these studies that actually had a recurrent episode. So I think it's a very small amount of the population included in these studies. So just to sort of reiterate that, the graphic that I have up here is taking a look at the studies and in terms of whether it favored Fidaxomicin or favored vancomycin, looking at relative risk rates and whether or not you cross one. So you can see that the top part of that is no clinical cure, and so you'll see that it crosses one in terms of favoring Fidaxomicin versus vancomycin. So approximately the same number of patients were cured of their Clostridium difficile. In the no clinical cure, looking at the modified intent to treat, also looking at per protocol, the therapy was not favoring Fidaxomicin over vancomycin. Looking at no global cure, it actually favors Fidaxomicin as well as with recurrence. So those are the patients that seem to benefit more from Fidaxomicin in these studies. So when I think about Fidaxomicin, I think the cost is so significant with it, and I think we have so few options for Clostridium difficile diarrhea that when I would consider using Fidaxomicin is when somebody who has had a recurrence of Clostridium difficile. So it's not specifically how it's been studied, but from a cost perspective and trying to preserve our antibiotics in terms of, I think using sort of a tiered approach, my thought is that I would use Fidaxomicin in patients who have had significant recurrence, particularly because it does look like it decreases the development of recurrence. So somebody who has either their first recurrence or second recurrence, and if I would kind of think about, they used metronidazole for their first episode, they've maybe tried vancomycin for a first or second recurrence. At that point, I would start thinking about going to Fidaxomicin. I think that's sort of that tiered approach that I would use. If they used vancomycin for their initial course, and then they were retreated with vancomycin and it's recurred a second time, at that point I would think about going to Fidaxomicin. So that's sort of my bias in terms of how I think about using Fidaxomicin, particularly with the cost associated with it. And I think it is important for us to be judicious with our use of some of these new antimicrobials, particularly in C. diff, where we don't have any other options to really go to. Certainly there's last line options talking about doing fecal transplants, using probiotics. There's other minimal data with some other antibiotics that's really not very promising, and it's really not very good data. So I think it's important that we use Fidaxomicin judiciously. The last slide before we get to our summary slide is about talking about preventing transmission. So Clostridium difficile is very easy to transmit from one person to another. So certainly we want to prevent transmission, particularly with patients in the hospital who have Clostridium difficile diarrhea. So there's a few key concepts to remember. So first, healthcare workers and visitors should wear gloves and gowns on entry to a room with a patient who has C. diff diarrhea. So contact precautions should also be in place. The next key piece to remember is the importance of hand hygiene. And I know every hospital, I think probably now, has alcohol-based sanitizers right outside the room for patients. But the key is to remember that the spores associated with the Clostridium difficile diarrhea are not killed by using those alcohol-based sanitizers. So you need to use soap and water. So you need to stand at the sink in the patient's room, use soap and water, do not use alcohol-based sanitizers. And it's important to educate the patient about this. It's important to educate everyone who's visiting the patient about the importance of using soap and water. Good old-fashioned soap and water, no alcohol-based sanitizer. So can't highlight that enough. Private rooms are recommended for patients who are infected, and I have seen times where they've put two patients who have C. diff in the same room, but you would want to try to give patients who are infected with C. diff their own private room to help prevent additional patients from developing C. diff. And then the last piece is that there's been a recommendation to use chlorine-containing cleaning products in the room once the patient has been discharged. And again, this has to do with the spores, so typical cleaning solutions cannot be used. They need to be chlorine-based to decrease the risk of the next patient to be in that room from getting Clostridium difficile diarrhea. So preventing transmission is a huge piece of this, and if you take nothing else away from preventing transmission, remember, always wash with soap and water when you've left the room of a patient who has Clostridium difficile diarrhea. So we've gone over a lot of information today about infectious diarrhea, and so just to summarize, diarrhea illness is a common infectious complaint for which patients seek health care, and so it's an important topic for us to be educated on. Evaluation of patient presentation and their epidemiologic risk factors is really the key to determining the likely pathogen as well as to determining the appropriate treatment. In terms of general treatment considerations, rehydration should be a part of the initial management of any patient with an infectious diarrhea illness. And you want to consider antimotility agents, remembering that you do not want to use antimotility agents. They are contraindicated in patients who have toxin-producing diarrhea. So specifically, antimotility agents should not be in a patient infected with Clostridium difficile. And then lastly, I think a key take-home point in treating patients with C. diff diarrhea, the most important clinical characteristics to keep in mind when we're talking about severity of illness and determining the most appropriate initial treatment is taking a look at the patient's white blood cell count and serum creatinine. So remembering to take a look at those numbers and evaluating whether the patient is most appropriate to receive metronidazole or vancomycin as their initial therapy.